Artificial intelligence-assisted optical diagnosis for the resect-and-discard strategy in clinical practice. The Artificial Intelligence BLI Characterization, ABC, study. Introduction. The implementation of clinical strategies based on optical diagnosis of diminutive colorectal polyps that are 5 millimeters or less may lead to a substantial saving of economic and financial resources. Despite this, 84% of European endoscopists reported not using such strategies, also known as the leave in situ and resect-and-discard strategies, in their practice owing to the fear of an incorrect optical diagnosis. Indeed, the accuracy of optical diagnosis is operator-dependent, and values reported in community settings are below the safety thresholds proposed for its incorporation in clinical practice. Because of its accuracy in discriminating different visual patterns, artificial intelligence, AI, has the potential to help endoscopists in distinguishing neoplastic from non-neoplastic polyps, making the characterization process more reliable and objective. Preliminary retrospective data in an artificial setting have shown high feasibility and accuracy levels of AI for optical diagnosis of colorectal polyps, especially when focusing on diminutive rectosigmoid polyps. Recently, AI-assisted endocytoscopy showed an adequate accuracy for rectosigmoid polyps 5 millimeters or less, achieving a 90% or greater negative predictive value for adenomatous histology in a real-time setting. Despite this, endocytoscopy is not widely used in Western countries, and it requires dedicated equipment and special skills that are not available in community endoscopy. In the present study, the authors exploited a new computer-aided diagnosis system that provides real-time polyp characterization with standard endoscopy. The study aimed to assess whether real-time AI-assisted optical diagnosis is accurate enough to implement the leave in situ strategy for diminutive rectosigmoid polyps. Methods: consecutive colonoscopy outpatients with one or more diminutive rectosigmoid polyps were included. Diminutive rectosigmoid polyps were categorized as adenomas or non-adenomas by the endoscopists, who had differing expertise in optical diagnosis, with the assistance of a real-time AI system. The primary endpoint was 90% or greater negative predictive value for adenomatous histology in high-confidence AI-assisted optical diagnosis of diminutive rectosigmoid polyps according to the Preservation and Incorporation of Valuable Endoscopic Innovations (PIVI-1) threshold, with histopathology as the reference standard. The agreement between optical and histology-based post-polypectomy surveillance intervals 90% or greater PIVI-2 threshold, was also calculated according to European Society of Gastrointestinal Endoscopy, ESGE, and United States Multi-Society Task Force, USMSTF, guidelines. Results. Overall, 596 diminutive rectosigmoid polyps were retrieved for histology in 389 patients. An AI-assisted high-confidence optical diagnosis was made in 92.3%. The negative predictive value of AI-assisted optical diagnosis for diminutive rectosigmoid polyps, PIVI-1, was 91.0%. The PIVI-2 threshold was met with 97.4% according to ESGE and 92.6% according to USMSTF of patients. AI-assisted optical diagnosis accuracy was significantly lower for non-experts than for experts. However, non-experts quickly approach the performance levels of experts over time. Conclusion: AI-assisted optical diagnosis matches the required PIVI thresholds. This does not, however, offset the need for endoscopists' high-level confidence and expertise. The AI system seems to be useful, especially for non-experts.